Bismillahirrahmanirrahim. Quote of the day. Allah does not burden a soul beyond that it can bear. The topic of my presentation is family planning, that is barrier methods and pills, and I am presenting it under kind supervision of Professor Dr. Sarah Afzal. Learning outlines are types of barrier methods, male condoms, female condoms, diaphragm, vaginal sponge, combined oral contraceptive pills, progesterone only pills, emergency contraceptive pills, and in the end we have recent updates in MCQ session. Learning outcomes. At the end of presentation, participants would be able to describe different barrier methods and oral pills with their benefits and health risks. Barrier methods. The aim of these methods is to prevent live sperm from meeting the ovum. They are categorized into three, that is physical method, chemical method, and combined. In physical method, we have condoms, female condoms, diaphragm, vaginal sponge. In chemical methods, we have foams, foam tablets or aerosols, creams, jellies, and paste, suppositories, and soluble J films. In combined method, we have the combination of physical method and chemical method. Condoms. Condom is an effective, simple spacing method of contraception without side effects. It prevents the semen from being deposited in vagina. The effectiveness of a condom may be increased by using it in conjunction with a spermicidal jelly inserted into the vagina before intercourse. Failure rates for the condom vary enormously. Surveys have reported pregnancy rates varying from 2 to 3 per 100 women years to more than 14 in typical users. Advantages are that they are easily available, safe and inexpensive, easy to use, do not require medical supervision, they have no side effects, are light, compact and disposable, and provides protection not only against pregnancy but also against sexually transmitted diseases. Disadvantages are that they may accidentally break or slip off during coitus, allergic reaction can occur, and failure rate is high. Female condoms. The female condom is a pouch made of polyurethane which lines the vagina. An internal ring in the close end of pouch covers the cervix and the external ring remains outside the vagina. It is pre-lubricated with silicone and a spermicide need not to be used. It is an effective barrier to the STDs, that is sexually transmitted diseases. However, high cost and acceptability are major problems. Failure rates during the first year use vary from 5 per 100 women years pregnancy rate to about 21 in typical users. Diaphragm. Diaphragm is a shallow cup made of synthetic rubber or plastic material. It ranges in diameter from 5 to 10 centimeter and has a flexible rim made of spring or metal. It is held in position partly by spring tension and partially by the vaginal muscle tone. This means for successful use, the vaginal tone must be reasonable. Otherwise, in the case of severe degree of cystocele, the rim may slip down. The diaphragm is inserted before contact and must remain in place for not less than 6 hours after the contact. A spermicidal jelly is always used along with diaphragm. The diaphragm holds the spermicide over the cervix. Side effects are practically nil. Failure rate for it with spermicide vary between 6 to 12 per 100 women years. Advantages are total absence of risks and medical contraindications. They are cheap, can be used repeatedly for a long time, and they reduces the chances of pelvic inflammatory disease and sexually transmitted disease to some extent. Disadvantages are initially a physician or other trained person will be needed to demonstrate the technique of inserting the diaphragm into the vagina and to ensure a proper fit. After delivery, it can be used only after involution of the uterus is completed. Practice at insertion, privacy for this to be carried out, and facilities for washing and storing the diaphragm precludes its use. If the diaphragm is left in vagina for extended period, there is a remote possibility of a toxic shock syndrome. Vaginal sponge. It is small polyurethane foam sponge measuring 5 into 2.5 centimeters saturated with spermicide nonoxynol line. The sponge is far less effective than the diaphragm, but it is better than nothing. Failure rates in parous women is between 20 to 40 per 100 women years, and in nulliparous women about 9 to 20 per 100 women years. Now, vaginal rings. These are the flexible ring that a woman places in her vagina, continuously releases two hormones, a progestin and an estrogen, like the natural hormones progesterone and estrogen in a woman's body from inside the ring. Hormones are absorbed through the wall of vagina directly into the bloodstream, and the ring is remained at place for 3 weeks, then is removed for the fourth week. During this fourth week, the woman will have monthly bleeding, or it is also called as Nuga ring. It works primarily by preventing the release of eggs from the ovaries. Now, the second method is chemical method. In this, commonly used as spermicides. These contain a base into which a spermicide is incorporated. The commonly used modern spermicides are surface active agents which attach themselves to spermatozoa, inhibit oxygen uptake, and kill sperm. The spermicide should be free from potential systemic toxicity. It should not have an inflammatory or carcinogenic effect on the vaginal skin or cervix. No spermicide which is safe to use has yet been found to be really effective in preventing pregnancy when used alone. Therefore, they are not recommended by professional advisors. They are best used in conjunction with barrier methods. Drawbacks of spermicide are: they have a high failure rate. They must be used almost immediately before the contact and repeated before each sex act. They must be introduced into those regions of vagina where sperms are likely to be deposited, and they may cause mild burning or irritation besides messiness. Now coming to our second topic, oral pills. These includes combined pills, that is combined oral contraceptive pills containing estrogen and progesterone. Then comes progesterone only pills, then comes postcoital pill, then once a month pill, and male pill. Combined pills, they contain both estrogen and progesterone. Combination birth control pills prevent ovaries from releasing an egg. They also cause changes in cervical mucus and the lining of uterus to keep sperm from joining the egg. Advantages: combination birth control pills are a reliable form of contraception that is easily reversed. Fertility can return to normal almost immediately after stopping the pills. Other non-contraceptive benefits of these pills include decreased risk of ovarian and endometrial cancers, ectopic pregnancy, ovarian cyst, benign breast disease, improvement in acne, less severe menstrual cramps, reduction in androgen production caused by polycystic ovary syndrome, reduction in heavy menstrual bleeding due to uterine fibroids and other causes, as well as reduction in related iron deficiency anemia, relief for premenstrual syndrome, shorter, lighter, and more predictable periods of for some time of combination pills, fewer periods yearly, better control of monthly cycle, and a reduction in hot flashes for women nearing menopause, that is for perimenopause women. Combination pills are categorized based on whether the dose of hormones stays the same or varies. These are three: monophasic, biphasic, triphasic. In monophasic, each active pill contains the same amount of estrogen and progestin. But in biphasic, active pills contain two combinations of estrogen and progestin. In triphasic pills, active pills contain three combinations of estrogen and progestin. In some types, the progestin content increases. In others, the progestin dose remains steady and the estrogen content increases. Choice of OCPs. There are usually two, that is conventional regimen and extended release. In conventional regimens, 21 days of active pills and 7 days of placebo. They are usually iron pills. They provide predictable menses. Because monophasic OCs may be easier to take, easier to identify and manage side effects, and easier to manipulate to alter the timing of the menstrual cycle, they are preferred over conventional biphasic or triphasic OCPs. Extended cycle OCPs either eliminate the menstrual cycle or result in only 4 menstrual cycles per year, so they may be associated with less dysmenorrhea and menstrual migraines. Commercially available extended cycle OCPs are available, or monophasic 28 days OCPs can be cycled by skipping the 7-day placebo phase for 2 to 3 cycles. Contraindications. These are usually not used when the female is pregnant or she has given birth in the last 3 weeks, or breastfeeding a baby less than a 6 months old, or having a high blood pressure, smoking cigarettes, and age is usually 35 or older, and having severe headaches, or have history or having breast cancer, having blood clots in her legs or lungs, having liver or gallbladder disease, had a stroke or heart attack, or had been told by a doctor that she has a lupus, or have diabetes. So the common contraindications are thrombophlebitis, chronic heart failure, other causes of edema, vaginal bleeding of undiagnosed etiology, known or suspected pregnancy, as we have discussed earlier, known or suspected breast cancer, or estrogen-dependent neoplasm, because they are aggravated in case of OCP's intake. Impaired hepatic functions, fibroid tumors, dyslipidemia, diabetes, hypertension, and migraine, lactating mothers. In case a female is lactating or she is obese or have age 35 years or more, then mini pills, or we can say only progestin pills, are recommended. Risk of conception in case of combined oral contraceptive pills. An estimated 9 out of 100 women taking combination birth control pills will get pregnant in the first year of use. With perfect use as directed, the pregnancy rate is less than 1 in 100 women every year. Now, the possible side effects are most common are nausea, stomach upset, changes in bleeding pattern that is irregular or infrequent or no monthly bleeding, mood changes or headaches, tender breast, dizziness, slight weight gain or loss. Now, second, oral pills, progesterone only pills. These are commonly referred to as mini pill or micro pill. They contain only progesterone, which is given in small doses throughout the cycle. The commonly used progesterones are norethindrone and levonorgestrel. The progesterone only pills never gained widespread use because of poor cycle control and increased pregnancy rate. The indications for it are it can be used for any woman seeking reliable, reversible, partly independent method of contraception in the absence of contraindications. Women with contraindications to estrogen, as we have discussed in our previous slides. Women with age more than 35 years and who smoke. Women having migraine headache with neurological symptoms. Women who have unwanted side effects of combined oral contraceptive pills, and breastfeeding women. The side effects are headache, breast tenderness, acne, hirsutism, nausea, spotting. Contraindications are non or suspected pregnancy, genital bleeding of unknown etiology, liver tumors, acute liver disease. Failure rate. It's estimated that as many as 13 out of 100 women who will use the mini pill will get pregnant in a year of use. Now coming to our third, that is postpartum pill or emergency contraception. It is a form of birth control used to help prevent a pregnancy from happening after having unprotected intercourse. Pregnancy can occur if a woman forgets to take her birth control pill or if a condom breaks or none is used. Emergency contraception also can be used in women who have been raped. Postcoital contraception, it is recommended within 72 hours of an unprotected intercourse. Two methods are available, Iud and hormonal. Iud is the simplest technique to insert an Iud if acceptable, especially a copper device, within 5 days. And hormonal, it is a hormonal method may be preferable in which levonorgestrel 0.75 mg tablet is approved for emergency contraception. It is used as one tablet within 72 hours of unprotected intercourse, and the second tablet after 12 hours of first dose. This is the most commonly used regimen. The other three are two oral contraceptive pills containing 50 mcg of ethinyl estradiol within 72 hours after intercourse, and the same dose after 12 hours. And the third is 4 oral contraceptive pills containing 30 or 35 mcg of ethinyl estradiol within 72 hours, and 4 tablets after 12 hours. And the last is mifepristone 10 mg once within 72 hours. Now, the effectiveness. If one pill is taken within 24 hours, then it offers protection up to 95%. And if the time gap is 25 to 48 hours, then it provides protection up to 85%. And if it is extended to 49 to 72 hours of unprotected contact, then it offers protection up to 58%. So the best is to take it as soon as possible. Emergency contraception can prevent up to 95% pregnancies when taken within 5 days after intercourse. The emergency contraceptive pill regimens recommended by WHO are ulipristal acetate, levonorgestrel, or combined oral contraceptives consisting of ethinyl estradiol plus levonorgestrel. The effectiveness can be seen in this picture. That is, if 100 women each had unprotected sex during the second or third week of the menstrual cycle, that is, if no ECPs are taken, then there are chances of 8 pregnancies per 100 women. If ulipristal acetate is taken, then there is a chance of less than 1 per 100 women. And if progestin only ECPs are taken, then there is chance of 1 pregnancy per 100 women. And if combined estrogen, progestin, ECPs are taken, then there is a chance of 2 pregnancies per 100 women. So the best option we have is ulipristal acetate. It provides the most effective contraception, and it is less than 1 pregnancy per 100 women. The indications for emergency contraception are, that is, intercourse within past 72 hours without contraceptive protection, contraceptive mishap, that is barrier method dislodgement, breakage, expulsion of IUD, missed oral contraceptive pills, sexual assault, exposure to teratogens. Common side effects. Changes in bleeding patterns, including slight irregular bleeding for 1 to 2 days after taking ECPs, monthly bleeding that starts earlier or later than expected, abdominal pain, feeling sick, tiredness. Now coming to recent updates. According to WHO report published in June 2020, these are the methods we have discussed with their effectiveness. For combined oral contraceptive pills, the effectiveness, that is pregnancies per 100 women per year with consistent and correct use, it is 0.3. And if it is seen in pregnancies per 100 women per year as commonly used, then we have 7%. And progesterone only pills or the mini pills, the same we have as we have in COCs, that is 0.3 pregnancy per 100 women per year with consistent and correct use, and 7 pregnancies per 100 women per year is commonly used. And for male condoms, we have 2 pregnancies per 100 women per year with consistent and correct use, and 13 pregnancies per 100 women per year as commonly used. And for female condoms, it is slightly increased. We can see the difference between male condoms and female condoms. For female condoms, the effectiveness is 5 pregnancies per 100 women per year with consistent and correct use, and 21 pregnancies per 100 women per year as commonly used. Emergency contraception. It can prevent up to over 95% of pregnancies when taken within 5 days after intercourse, and it is used in the following situations: unprotected intercourse, concerns about possible contraceptive failure, incorrect use of contraceptive, and sexual assault if without contraception coverage. The methods recommended by WHO are ECPs with ulipristal acetate taken as a single dose of 30 mg, and ECPs with levonorgestrel taken as a single dose of 1.5 mg, or alternatively levonorgestrel taken in 2 doses of 0.75 mg each, 12 hours apart. And combined oral contraceptive pill taken as a split dose, 1 dose of 100 microgram of ethinyl estradiol plus 0.5 mg of levonorgestrel, followed by a second dose of 100 microgram of ethinyl estradiol plus 0.50 mg of levonorgestrel 12 hours later. It is also called USP method. And the most commonly 4 methods of emergency contraception are ECPs containing ulipristal acetate, ECPs containing levonorgestrel, combined oral contraceptive pills, and copper bearing lipid devices. Effectiveness. A meta-analysis of two studies showed that women who used emergency contraceptive pills with ulipristal acetate had a pregnancy rate of 1.2%. Studies have shown that ECPs with levonorgestrel had a pregnancy rate of 1.2% to 2.1%. Ideally, ECPs with ulipristate acetate, ECPs with levonorgestrel, or combined oral contraceptive pills should be taken as early as possible after unprotected intercourse within 120 hours. ECPs with ulipristate acetate are more effective between 72 to 120 hours after unprotected intercourse than other ECPs. Now, advances in contraceptive vaginal rings. This was a paper published, and according to it, it provides a review of the development made with combined vaginal rings over the past number of years, while giving focus to the latest combined vaginal rings that have gone through clinical development. Pharmacokinetic studies have shown that progesterone and absorbable progesterone that is used alone or in combination with ethinyl estradiol is the combined vaginal ring of choice at this present time. It has demonstrated safety and efficacy and is also an appropriate option for lactating women as they are not absorbed orally. Otherwise, we have already discussed that combined pills are not taken by lactating mothers, but there is coming advancement in combined vaginal rings where it can be used by the lactating mothers. The main highlights of this article were that in combined vaginal rings, vaginal absorption and the constant release of steroids favor better cycle control and fewer side effects because there is no initial hepatic passage. Combined vaginal ring with ethinyl estradiol is a combined and effective combined vaginal ring with high satisfaction rates, and it is still not used very worldwide. The combined CVR containing ethinyl estradiol and progesterone is a newly developed combined CVR that could also be well accepted, and it has high rates of amenorrhea in breastfeeding user. Despite its good acceptability, it still has very limited use globally. CVRs containing progesterone, it is a good option in lactating women as they are not absorbed orally. And new models and new polymers that can be reused for a long time have been developed to prevent the initial burst effect, reducing the cost and impact on the environment. And CVR that allow the use of more than one drug in the same ring may combine a contraceptive effect with protection against sexually transmitted infections, especially HIV. Coming to our next, it is oral contraceptives and cancer risk. We have seen that it increases the risk of certain cancers, that is breast cancer and cervical cancer, and it reduces the risk of endometrial cancer, ovarian cancer, and colorectal cancer. And breast cancer analysis of data from more than 150,000 women who participated in 54 epidemiologic studies showed that overall women had ever used oral contraceptives had a slight increase in the relative risk of breast cancer compared with women who had never used OCPs. Cervical cancers. Women who have used OCPs for 5 years or more years have a high risk of cervical cancer than women who never used OCPs. The longer a woman uses OCPs, the greater the increase in her risk of cervical cancer. One study found a 10% increased risk for less than 5 years of use, a 60% increased risk with 5 to 9 years of use, and a doubling of the risk with 10 or more years of use. However, the risk has been found to decline over time after women stop using OCPs. Endometrial cancer. Women who have never used or who have ever used OCPs have a lower risk of endometrial cancer than women who have never used OCPs. Risk is reduced by at least 30% with a greater risk reduction the longer OCPs were used. Ovarian cancer. Women who have ever used OCPs have a 30 to 50% lower risk of ovarian cancer than women who have never used OCPs. Now, how could oral contraceptives influence cancer risk? The reason behind it is that naturally occurring estrogen and progesterone stimulate the development and growth of some cancers. For example, cancer that express receptors for these hormones, such as breast cancer. Because birth control pills contain synthetic version of these female hormones, they could potentially also increase cancer risk. And how it decreases the risk of certain cancer, it is by that it suppresses endometrial cell proliferation, thus reduces the risk of endometrial cancer. It reduces the number of ovulations as a woman experiences in her lifetime, thereby reduces exposure to naturally occurring female hormones, thus decreases the risk of ovarian cancer. It lowers the levels of bile acids in the blood for women taking OCPs, and so thus it reduces the risk of colorectal cancer. Once a month birth control pill is in the works. Researchers have developed a once a month oral contraceptive pill that say would offer women more choice and control over their fertility. Once swallowed, the pill remains in the stomach for weeks, slowly releasing hormones to prevent a pregnancy. It is specially designed to resist immediate attack by stomach acid. A US team has tested it in pigs and hopes human trials can start within a few years. The researchers say it would be a good option for women who want to take a tablet for birth control but are worried about remembering to take a daily dose. The once a month birth control pill is embedded into a starfish like organic device and packed into a capsule that can be swallowed according to the study. Once the capsule reaches the stomach, it dissolves and releases the starfish contraption, which then extends out to 6 arms, get lodged in place, and slowly delivers hormones. In the US, around 12.6 of women use an OCPs according to CDC, but failure to take the pill at the same time every day or forgetting to take the pill can increase the risk of pregnancy. So in order to overcome this problem, there is ongoing work on once a month pill. Now coming to MCQ session. A young couple visits family planning center to seek the best option for contraception as a male partner is recently diagnosed with HIV. Which of the following contraceptive method provides best protection against the transmission of HIV? Male
Delta
yes,
A.
the right answer is A. A young 30-year-old lady wants to take OCPs for birth spacing after having 2 kids, but she is worrisome about the side effects associated with them for which she needs counseling. Which of the following is their side effect? OCPs increases the risk of infertility when stopped. Women need to take rest as they build up in the body. They cause breast cancer. They cause multiple births.
C.
Yes, C is the right option. Others are mm, becoming popular as myths. These are myths. These are not the side effects. MCQ number 3. A researcher wanted to study and combine oral contraceptive pills by doing randomized control trial. Which of the following women can be taken for research purpose? Women with varicose veins, elderly women who smoke excessively, women with DVT, women with family history of breast cancer.
D.
The right answer is A, women with varicose veins, because they can be taken and they can be given oral contraceptive pills and studied for research purpose, while others are the contraindications for OCPs intake, as we have discussed in our previous slides. MCQ number 4. A young lady using COCPs as contraception for last 1 year presented to OPD for her unusual vaginal discharge and lower abdominal pain. Which of the following conditions could aggravate by combined oral contraceptive pills? Endometriosis, dysmenorrhea, premenstrual syndrome, genital fungal infection.
Delta
Yes, right answer is genital fungal infection, because when OCPs are taken, the estrogen causes change in vaginal pH that leads to the fungal development of fungal infection, vaginal fungal infection, and others are not aggravated. Others are they are relieved to some extent by intake of COCPs. A 36-year-old female delivered her third baby. She is breastfeeding her child, so she wants to get the contraceptive method that does not affect her breastfeeding. What would be the best option for her? Combined oral contraceptive pills, progestin only
B.
pills, emergency contraceptive pills, or combined vaginal ring?
Beta.
Yes, right answer is progestin only pills. This is the best option for lactating mothers. 100 women had intercourse once during the second or third week of the menstrual cycle without using contraception. Which of the following is not true regarding the effectiveness of emergency contraceptive pills? 8 pregnancies with no ECP, more than 1 pregnancy with ulipristal acetate, 1 pregnancy with progesterone only.
Beta.
Yes, the right answer is B, because the effectiveness is less than 1 pregnancy per 100 women with ulipristal acetate. MCQ number 7. Contraceptive vaginal rings are good contraceptive options as they do not require skilled providers and they are self-administered and show a higher stability of drug diffusion. Which of the following is true about them? Need to be placed for 3 months, then discarded. Provides protection against STDs. Provides protection against vaginal infection. Provides protection against pregnancy as COCPs do.
Delta.
Yes, right answer is delta because they combined have the same proportion of estrogen progesterone as COCPs do have. MCQ number 8. The combined oral contraceptive pill besides being used as a method of contraception can be used to treat the following except endometriosis, ovulation pain, menorrhagia, dysmenorrhea, ovarian cyst.
Ovarian cyst.
Yes, right answer
Ovarian
is
cyst.
ovarian cyst. COCVs are also called the pill, low dose combined pills work primarily by preventing the release of eggs from the ovaries. Which of the following is true regarding the risk of cancer associated with them? Reduced risk of endometrial cancer, increased risk of ovarian cancer, reduced risk of breast cancer, reduced risk of cervical cancer, worsen endometriosis as it contains estrogen.
Alpha.
Yes, the right answer is A because as we have discussed in our recent advances that it reduces the risk of endometrial cancer. Last MCQ, mechanism of OCPs include all of the following except ovulation suppression, enhanced ovarian androgen production, altered cervical mucus, altered endometrium, altered tubal motility. The right answer is B, enhanced ovarian androgen production because it has, yes, the right answer is B. This is the key. These are the references. Thank you.
Okay, thank you very much, Dr. Meha. Very nice presentation. However, there are few points that has been missed. That is about the absolute contraindication and relative contraindications of hormonal contraceptive methods. Would you please like to elaborate on the absolute contraindications and relative contraindications?
Ma'am, relative contraindications include that if a woman's age is 35 or older, or she is obese, smoker, while or she has history of breast cancer, while in absolute contraindication.
And sorry, and what about lactating women?
Yes, lactation is also an relative contraindication. While absolute
Of combined oral contraceptives. No, you have to make it a slide here.
okay, ma'am.
Sorry, I haven't. You have to make a slide about the relative contraindication of combined oral contraceptive pills and hormonal methods, because lactation is one of the contraindication of the combined oral contraceptive pills or hormonal method. It is not for the progesterone only methods or progesterone acetate or the some injectables that are only consisting of progestin. Then it is not a contraindication, right?
Yes,
So
ma'am.
you have to make a slide about it. Okay, and what are the absolute contraindications?
Absolute contraindications are DVT or a woman having prosthetic valves or any heart disease and sickle cell anemia, any clotting defect she is having. These are the absolute contraindications.
You have to make another slide of the absolute contraindications of OCPs, as we know that there are many people who are using oral contraceptive pills without having much knowledge about it. And they usually end up with ischemic heart disease or myocardial infarction. So it is one of the absolute contraindication. Ischemic heart disease, as you have said, thromboembolic conditions And another important thing is migraine. Migraine is worsened by using oral contraceptive pills. Similarly, is the case with hypertension. It is one of the contraindication, uncontrolled hypertension. And jaundice. Similarly, those women who have the family history of CA breast, CA cervix, as you have shown in your recent advances, that both CA breast and CA cervix, it is associated with OCPs. However, the risk is much lesser than other cancers, but still it is the contraindication. Similarly, those women who have liver diseases, they are having the absolute contraindication, especially chronic liver disease, having cirrhosis, or any acute liver failure, like fulminant hepatic failure. Similarly, the dyslipidemia, as it increases the risk of ischemic heart disease, again, it is one of the contraindication. We know that there are certain side effects of the hormonal method that must be explained so that a person can have a better compliance with the hormonal methods. And that include the breast tenderness or lump. We also know that if there are irregular menstrual bleeding, then it can be used therapeutically. However, there are the chances that after using, especially of progesterone containing contraceptives, there is a chance of irregular menstrual bleeding, spotting, again weight gain, headache, and there must be a check on blood pressure because hypertension is associated with hormonal methods. We know that the dyslipidemia, again, it is something that has to be checked before giving any type of hormonal methods. So these are some of the points that are very important here, and we know that the mechanism of action as it alters the neuroendocrine feedback system. So any disease that is related with hypothalamic pituitary ovarian relationship, that is again one of the consideration that should be looked for before giving any hormonal methods. So these are a few points that must be added. Otherwise, it is a very good presentation. If anybody has any question, you are most welcome to ask. Okay, thank you very much. See you next time. Allah Hafiz.